So when performing an upper limb assessment of somebody's neurological function, again, the first thing to do is have the patient adequately exposed, and usually in a formal examination setting, that would involve having the patient sitting on the edge of the bed in the underwear. And again, the first thing to do is start with a visual inspection, looking for muscle wasting, fasciculations, surgical scars. It's important to check the back for scoliosis or kyphosis. Other clues could be breast surgery or axillary clearances, which may lead to brachial nerve plexus injuries. And once you've established that there's no overt signs of neurological disease, a quick overall assessment of upper limb function is to just ask the patient to extend their arms, palms up, and ask the patient to close their eyes and look for any signs of a pronator drift, in which case the abnormal reflex would be that the arm lacks strength and pronates. Good, so we just get the patient to relax. And now the formal examination involves following the procedure of testing for tone, power, reflexes, coordination and sensation. And when testing for tone, we test at the elbow and at the wrist joint, and we just ask the patient to relax and assess the joint movement. Make sure, particularly in the elbow, we're looking for lead pipe rigidity, and in the wrist we're looking for cogwheeling rigidity. Assessing the power of the upper limbs, we ask the patient to assume the chicken wing position with elbows up, and we ask them to hold them there against resistance. Good, and again push down against my hands against resistance. Good. The next muscle group to assess is the biceps at the elbow. Ask the patient to put their arms up, stabilising the joint this time from behind. Ask the patient to push my hand away. Good, pull my hand back in, and again on the other side, push away, pull my hand back in, and of course the power should be equal on both sides. Examining power at the wrist, we just get the patient to extend their hands like so, and just gently get the patient to hold against resistance. Good, and again hold against resistance, again stabilising the joint below. Good. While the patient's hands are there, fingers open, assessing the small muscles of the hand by squeezing the fingers, and hopefully the person should be able to hold against resistance. And finally ask the person to squeeze the fingers and don't let go. Good. And again, hold nice and tight, don't let go. Good. Assessing the reflexes, there are 3 reflexes to assess in the upper limb. The biceps reflex, brachioradialis and triceps. And it's done just by getting the patient to pop their hand on the lap, nice and relaxed. Palpate the biceps tendon with the thumb. Good. Normal reflex, again, brachioradialis. Good. And finally, the triceps, just hold the patient's hand, and so the patient's arm should be loose, and I should be holding all the weight. Again, just palpate the triceps tendon. Good. And present reflex. And again, the reflexes should be symmetrical on both sides. Assessing coordination, again, a quick functional assessment of coordination, just asking the patient to play the piano for me. Good. And just rub your hands. Good. So coordination is grossly intact. But for a more formal test, we start by testing dysdiadochokinesis, where first of all we just ask the patient to tap their hands, just normally first, and then back and forward as fast as they can. Good. And then of course examine the other hand as well. Very good. And the next test for coordination is the finger-nose test. So get the patient to first of all touch their nose with their index finger, and then at a full arm stretch, touch my finger. Good, and back and forwards as fast as you can. Good, and then finally ballistic tracking. So the patient, if I move my finger, the patient should be able to track. Good. Good, okay. And again, it should be compared with the other side as well. Testing sensation is done in 2 ways. First of all, testing for a peripheral neuropathy or an ascending neuropathy. It's just done by testing, first of all, if the patient can feel the pinprick is sharp on their chest, and then if they can feel it as sharp coming up the hand, it should feel the same. And then the next step is to test each dermatome individually. Sharp?
Yes,
sharp. Sharp, sharp. Good. And shouldn't do it through the clothes. And the final test for sensation is to test vibration sense or proprioception, as they both involve dorsal column pathway. So with the tuning fork, On the tip of the finger, first of all, which is a bony prominence. Can the patient feel the vibration?
Yes.
Yes. And if they couldn't feel the vibration, you'd work your way up, styloid process, elbow, and finally AC joint, which are the bony prominences to test. So once again, Claire's upper limb examination, normal.